Hi, Gibson, Greg Stone coming to you from Snackable Health, and we're talking about the management of cardiogenic shock. Lots of controversy out there, Greg, lots of observational data, lots of noise, but not a lot of definitive data. And you are now launching the Recover 4 trial. Talk to us a little bit about what's going on in the field and what you hope to answer with Recover 4.
Well, thanks, Mike. It wouldn't be an overstretch to say that trying to improve outcomes for patients with acute myocardial infarction and cardiogenic shock is really the holy grail of cardiology. I mean, up to 50% of these patients die within 30 days, and we've made very little progress over the last 20 years. In fact, there's some evidence that mortality in cardiogenic shock is increasing slightly over the last couple of decades. Primary PCI was really the last big major advance that reduced mortality in cardiogenic shock. But since then, many other pharmacologic and device-based adjuncts have been tried and have failed. So the concept of using a potent acute mechanical circulatory support with a transaxial micro flow pump, such as the Impella CP device, to unload the left ventricle, improve cardiac power output, and support the ventricle while it's basically recovering from an acute myocardial infarction, has a lot of experimental data to support its potential benefits. But when one looks at the data that we have from what is mostly observational studies, there's a lot of conflicting data. And I don't have to tell you that observational data is really fraught because of the issue of unmeasured confounders. We can never really tell why was a patient with cardiogenic shock treated with pressors only versus a balloon pump only versus an Impella versus ECMO, for example. And much of this data comes from administrative insurance-based claims data, and they don't collect lactate levels or cardiac power output or even the stage of shock, or certainly don't prospectively collect why one device was used versus the other. So as you know, only randomized trials can really answer this question. And in the past, these trials have proven very, very difficult to do. There have been some prior trials of advanced mechanical circulatory support in cardiogenic shock. The only one really of note was that done with a balloon pump by Holotile, and it had negative effect, totally neutral effect on both early and late mortality. So balloon pumps are not routinely used anymore in cardiogenic shock, particularly in Europe. So Impella, particularly the CP device, without any question, provides much greater hemodynamic support than an atrial balloon pump. And you've got people who are very strong proponents that say they would never take care of a true shock patient without an Impella device. And you have others that say this is a large bore device and it might increase bleeding and vascular complications and it may do harm. And you can find data in the literature to support both of those opinions. So for many years in Europe, there's been a trial, a randomized trial called DanGer. It initially started in Denmark and then spread to Germany and now actually involves the UK site, which is trying to randomize 360 patients to Impella versus standard of care, which in Europe is basically pressors only. And they're making very slow progress. It's been going on for, I guess, gosh, up to a decade now. And probably in another year, I think they will randomize. But we've learned an awful lot since DanGer started, in particular in terms of best practices, how to use Impella most safely with ultrasound-guided puncture and placement in and taking it out in the cath lab and other parameters that have markedly been associated with decreased bleeding and vascular complications. And so with the full support of the FDA, we've now designed and just announced FDA approval for the Recover 4 trial. And this is a 548 patient randomized trial, which will be done inside and outside the United States at up to approximately 50 sites. And we're going to randomize patients with true cardiogenic shock, but patients who are not comatose, patients who can have some expectation for recovery, to either the control arm, which will be either pressors only or an intra-aortic balloon pump with pressors, according to site preference, versus an Impella CP device. And there'll be no crossovers allowed in between the two arms. So the major escalation will be to devices such as ECMO or tandem heart if necessary. And the primary endpoint for this trial is mortality at 30 days. We're very excited to now have FDA approval, as I mentioned, and we'll hopefully start enrolling patients later this year.